Hello, everyone. Thank you so much for spending your time with me as we jump into this new code and what it's going to mean for you. My name is Teresa Duncan, and we are here tonight to discuss a new periodontal code. It's here, and now what are we going to do with it? A little bit about me is that I have been in the dental industry for over 20 years, and I have been doing insurance for an awful long time, filing claims, and I still actually do it to this day for my clients. And so I'm still on the phone with them. I'm still talking to them on a regular basis. And now I get to see a little bit more of the behind the scenes when it comes to insurance. I am thrilled to be here and to present this side of the equation when it comes to insurance coding. This code is a long time coming. What I am really worried about, though, with this code is that there is going to be a lot of misconception about how to use it and what instances we should be billing for it. And so hopefully after today's webinar, you'll have a much better idea of how to handle it in your practice. As we proceed through, what I want you to keep in mind are two factors. And so, jot this down before we get started. I'm not going to advance the slide for just a couple seconds here. So what I'd like you to do is think about this. Are you ready, documentation-wise, for me to file these claims and to get paid for this new code? Are you, doctors and hygienists, are you ready for that documentation-wise? And the second factor I'd like you to continue is, are you ready verbal skills wise? So verbally, do you have the knowledge, do you have, I guess, the skill to talk to your patients about what this procedure is, this procedure that you probably have been doing for quite some time. It's just now we need to present it to the patient in a different light because benefits are involved. So think about those two things. Is your documentation ready? Are your verbal skills ready? And that also means, is your team ready? So your records and your team are what I'd like you to think about as we go through this. And, I've always said a good team drives a good office, and I'd like to add the good records and documentation in this case are going to drive your revenue as well. Currently, we have these options for periodontal coding. They're healthy, they're kind of healthy, they're not healthy, maybe they're just a mess. There are gaps in how we can code, though. I often hear surprise when I mention D199 or D499 because we don't really think about it. It's not part of our protocol. In fact, D1999 is one of those newer codes as well that most people just don't think about. We didn't have a 1999 code for a long, long time, and it sounds like a rhyme, doesn't it? And it sounds like, and it is actually a very useful code. However, your insurance coordinators that are on the call, anything that ends in a 999 typically is not a paid procedure. We pretty much have to, squeeze blood from a stone in order to get a 999 code paid. But there is that opportunity to use those procedure codes to describe any periodontal procedure, actually any procedure that doesn't quite fit the code description, which is why I'm excited that 4346 has come around, because there has been a gap in the code for just so long, and now we have that ability to close that gap. So it's a very good time for the doctor and the hygiene department to collaborate together and to revisit these set protocols. For example, when I say set protocols, for the 4999 and the 1999, a lot of times they're not used just because we forget to use them. We're so used to using, it's either 1110 or 4910. I don't even have that on here as a periodontal maintenance. I'm talking about for your initial, procedures, your initial treatment of the patient's soft tissue. So we don't think about the different codes that are out there because we're so used to using the same codes over and over again. And I run into that quite often when I take a look at someone's service mix, meaning their procedure code mix. I'll ask them, why are you using this particular code? Did you not know about this code? And they'll say, oh, I didn't even think of that. It's in our auto notes, it's in our multi-codes. We don't think about, changing it up because, if it's not broken, don't fix it. And so this is a really good time to go back and revisit those protocols. And as an insurance coordinator, as your insurance coordinator, I'm a helpful observer in this conversation. And so when the clinicians meet to go over these periodontal protocols, I'm really just sitting on the sidelines. I'm not going to influence the protocol. That's not my job. I'm not trained for that. I didn't go to school for that. But what I do know is insurance codes inside out. And so I'm going to sit there and tell you whatever you decide, whatever code you want to use, that is actually what I'm going to tell you what I need in order to be paid for that code. So again, I'm not there to influence your clinical decision making. I have no reason to do that. There's no, it's actually not a good thing for me to do that. What I'm there is to tell you what I'm going to need in order to get that procedure code paid. So I should not influence you on that. So in comes, because there is that gap that we talked about, in comes this new long-awaited code, and here it is. And I've bolded it. I've bolded parts of it for you, and I want to call out that in the actual coding guideline, of course, there is no bolding in the descriptor there. So that is not actually the ADA that's done that. I bolded it strictly for illustrative purposes. And so I am a license holder for the ADA. I do pay my license every year in order to use the codes in lectures. And so I just took the liberty to call out some of the language in the code for the purposes of this webinar. And so let's go over, I want to call out a few things. The first issue that is not called out, and I'll just show my cursor here so you can see. Full mouth, if you can see where I am, I'm in the top part there. This is scaling in the presence of generalized, all over the mouth, moderate or severe gingival inflammation. And it says quite clearly in there, and just put a pin in that because I'm going to come back to that after a little bit. Full mouth, and again, after oral evaluation. And so 4346 is not one of those preliminary codes where the patient comes in and right away we say, oh geez, let's just get going with 4346, and the doctor has not made any kind of diagnosis or prescription on that. It is for after an oral evaluation. And the next part of this is the removal. It is the removal of plaque, calculus, and stains from supra and subgingival tooth surfaces, so above and below the gums, where there is, and again, there's that generalized word, which you need to hang on to, generalized, moderate, or severe gingival inflammation in the absence of periodontitis. So there is no periodontitis there. And if your team is not clear on periodontitis, gingivitis, the differences, may I suggest that that is one of the first items that you tackle in a team meeting. And I will tell you from years of training front office administrative personnel is that they don't have the clinical knowledge, not because they just don't get it, it's just because no one took the time to explain it to them. So many of you doctors out there, you may assume that your team knows the difference between gingivitis, periodontal disease, periodontitis, what are the different mild, moderate, severe. We may not, and it's just because we've been talking about them for a long time, we may not actually understand it. We just know what it means as far as billing goes. So that would probably be a real team meeting. Don't just say, hey, do you guys know what's going on with this and what it means? Actually take the time to explain it, and I think you'll have a couple of employees who are very grateful for that. Let's go back to the orange. It is indicated for patients who have swollen, inflamed gingiva, generalized suprabony, that's above the bone, pockets, and then moderate to severe bleeding on probing. It should not be reported in conjunction with prophy, our scaling and root planing, or our debridement procedures. So that's the full text of the code, and there's just a lot there. You really could parse this out. The absence of the periodontitis, it just means there's no diagnosis of periodontitis. And so, you know, as an insurance coordinator, when I look in the record, if I see that there's been a diagnosis of periodontitis, then that tells me I can't use this code. So doctors, that's why the documentation piece is just so important. But so say there is no periodontitis documentation in the record. Is there something else there that could point me use this code, or that this code is the most appropriate when it comes to how to describe what you did? Is there a diagnosis of something? If I see that there's generalized moderate gingival inflammation, most likely this is where I'm going to go. I'm going to take a look at this and I'm going to match up my descriptors. I'm going to match up my records, and looks good. So that's the real advantage of having a good, solid documentation meeting so that everybody is on the same page. So going back to what we see right now, where does this code fit? Absolutely, it fits right square in the middle of this slide, and I'll show you why. So a patient that needs debridement, they've just got too much of everything. You know what this patient is. They come in and they've just got fuzzy stuff all over their teeth. That's not this person. You can't even see in there to do an evaluation, and so that is what you do before an evaluation. You get past the evaluation and you have to make a decision. Does the patient just need a cleaning, or because no bone loss and no bleeding, or does the patient go into scaling and root planing because you do see bone loss and you do see bleeding? Or is it more severe than that and the patient actually needs osteosurgery or referral to a specialist, what have you. So there's a great big gap right in the middle of this slide, and so offices were actually having to either down code, or because it wasn't quite a scaling and root planing patient, maybe it was somebody with a little bit of bleeding but no bone loss. So would they bill it as an SRP? Well, maybe it was a little too bloody, and so they billed it as an SRP, but maybe they shouldn't have billed it as an SRP because there's actually no bone loss. And so as long as I've been talking about insurance, I've heard the question, why don't they bring back the difficult prophy code? And that's a good code for those of you who have ever wondered about that, because that's really where this fits. It addresses this gap. No pun intended. Well, okay, maybe a little pun intended. But it addresses this gap, which is bleeding and no bone loss. So I've got a patient in the chair, they're puffy gums, they're bleeding, but when you probe, there's no bone loss. And so there's no 2-3 millimeter pockets, but they're just inflamed. So what about that patient? Well, now we have this code 4346, and the code is meant for those situations where we could bring them back from the edge and take them back to that healthy mouth that we could take care of if we just had a chance to get in there and do some preliminary work on them. What's interesting is that many of you have been doing this all along and have had to make that coding decision. Do I charge for just a cleaning? And I hate saying just a cleaning because it's work. It's not just a cleaning. But do I charge for a 1110, or do I numb them up and go crazy and go for the 4341 or 4342? And this is why we need to look at our periodontal protocol so that we have this all set. Again, there is always clinical judgment that could come in and upset that, but for the most part, if you've got some set protocol there is really no reason why you can't have the majority of the patients fit somewhere in your continuum. So let's look into the next part of 4346, and we'll get back to the clinical in a minute because you can't talk about billing without the clinical piece, but let's just real quick touch on the coding part. If you've ever attended any of my classes, then you know that I believe very strongly that a successful office is one in which billing and clinical, those two teams work together and they talk to each other and they understand what they need from one another. Clinical leads the way, though, and in this new insurance environment, it's going to be your documentation that drives your revenue. So when I say clinical leads the way, I always get some looks from the audience members because I know what that's like. I've been, like I told you, I've been in dentistry for over 20 years, worked as an office manager for an awful long time, managed many employees, and when it came to billing and coding, the buck usually stopped with me because I was the one who just knew the codes inside out. Well, I get that. And so when I say the clinical leads the way, I'm sure there's a lot of you out there that are thinking, well, wait a second, they don't know the codes. And I know they don't. What we have to do, though, is to educate them. And so clinical team members, the onus is on you to educate us about the clinical part of it. There's a synergy there that is really wonderful when it works well together. When those two teams don't talk to each other and are constantly butting heads, and I'm not talking personality-wise, I'm talking just coding and documentation-wise, then you have issues and you have inconsistent billing. And so that's why I really do need you to all get on the same page when it comes to documentation. As your insurance coordinator, I would look at the policies to see the criteria. And what I mean by that is patient comes in, they have a brand new insurance plan, and they are showing me what is covered, what is not, and we'll talk about which category this is going to go into. So we haven't gotten there yet. So as far as when I look at a policy, I'm always going to look for my deductibles. I'm going to look for my maximums. I'm going to look for my exclusions. I'm going to look for limitations. And as an insurance coordinator, I'm going to pay attention to the guidance that's been given to me about this code, because that's what I'm going to convey down to you as far as documentation needs. So the most priceless guide that I've seen on this has been the ADA's guide to 4346. And if you're an American Dental Association, if you're a member of the ADA, I'm not sure if this is available publicly, but if you're a member of the ADA, it's a wonderful PDF paper that explains this and the reasoning behind the code, because as you know, it is the ADA who owns the codes. And so they work with a committee in order to come up with this. And so who better to write the guide than them. So the appropriate use of it in the coding guide, it called out that there are 30% or more of teeth are involved, which leads to generalized. And if you noticed, and it means generalized. So if you notice when I looked at the code description, I kept calling that out, that it was generalized, and that'll come into play in a little bit. It also spoke about the use of a gingival index, and that's actually not on the slide, but it will be later on a slide in just a little bit. But it talked about using a gingival index, and so I urge you to talk to your clinical team. If you're not sure what the heck I'm talking about, that's okay. If you're an administrative person, you've never heard of gingival index until you needed to, and so that's when you're going to check with your clinical team members, your doctor, your hygienist, to find out what is this index and how do I get a hold of it and where do I see it in the chart. That's the real key. As a coder, I keep time used. That's mostly a medical or a sedation issue. You see that a lot in hospitals and of course in the offices that bill out for sedation. They measure things by time. Typically the only thing a general dentist office measures by time is the missed appointments that they have, that we have to assess a bill, and then that's a whole different topic because that missed appointment fee is something else, huh? So we don't really do that in dental. If my doctor says, well, but it took a long time, that really, I can't do anything with that. I sympathize. I realize that the person was just a bloody mess, and you really had to, spend a lot of time, and you had to, there was that education piece that went into it, but we don't really have reimbursement available for that. That's really all wrapped up into the code. So, please don't come to me and say, this just took extra, or this just was more difficult than I thought it was going to be. I sympathize. But when I look at my coding, I really don't have anything for you. So I suppose you could, instead of billing it 4346, you could do a 4999 code, but we've already talked about what the 999s mean. I don't really have a lot of faith in getting that paid. Probably they're going to push you back to a 4346 once they take a look at the documentation. So if you say to me, say you take a look at this code and you're thinking of how you're going to work it in, there is always a temptation to see if we can work it into our existing protocol and make it a little extra. And it's not really meant to be a little extra. It's meant to be a therapeutic procedure. And so if you say to me, well, let's get them in and let's do a 4355, which is the debridement, then let's do a 1110, then let's do a 4346, and then let's do a 4341. And I'm hoping that most of you that heard me go through that whole litany of codes realizes that that's pretty wrong. So that is not an appropriate use of the code. That's really what we call upcoding. That's really not what it's for. And so I really hope that you wouldn't make me uncomfortable enough to have to tell you that that's not really appropriate or ethical. And so just very quickly, and I won't say much more about this, but if you're listening to this this course and you have either an owner or an associate and they are pushing you to bill and code unethically, just know that it's not, you certainly are able to go find an office that doesn't have that kind of criteria. I see lots of them. And as an insurance coder, I certainly would hope that I wouldn't be put in that uncomfortable situation. I hope none of you are in a situation. So as your coordinator, I'm going to have a couple main questions when it comes to this code. Any insurance coordinator that's been doing this a long time will tell you that when we get the code book, we sit and we read it. We're coding nerds. We like to read the codes, and we like to see if there's any opportunity or if there's anything that we need to strike from our regular protocol, and then we're going to talk to you about it. So the questions I have around 4346 are on the screen. So what I had is I'm sure what your team is going to have. So is this going to be a preventive, or is this going to be a periodontal reimbursement? Which category is it going to fall into? Are we going to be able to bill for 1110 or 4910 on the same day? I mean, what happens if we've got one section of the mouth that's bleeding but no bone loss, but the other side has bone loss or is completely healthy? What do we do in those situations? Is this going to affect frequency limitations? In the 4000s, the periodontal coding, there are many frequency limitations that we have to worry about. What am I going to need to send in to receive payment? What is my documentation? What do I need to actually attach? Hopefully electronically. I'm hoping all of you are attaching your documentation electronically. What do I need to send in to receive payment? And then what is my diagnosis that's needed in order to get paid? So right now, I would bet that most of you don't really pay, my insurance coordinators I'm speaking to, don't really pay attention to the diagnosis needed. And I don't know if I blame you, because we've really never had to. Unless you billed medically, then you know how very important diagnosis is. But if you haven't billed medically, then you're not sure why this even needs to be paid attention to. Well, it does need to be paid attention to, and in the next coming years, this is going to impact your job and the role of the insurance coordinator much more so than probably any development in the insurance industry, because it's going to change the way we bill. So diagnosis is going to definitely be needed, and it's going to be up to the team to get together and make sure that we're documenting that correctly. So before I answer all of these definitively, you should know that I really can't answer them definitively, and I will tell you why. Because not even the payers are sure how they're going to work this. And that's not a knock on them. They just don't know. Remember, this code was just handed down at the Code Revision Committee, which happened in February. And so this code just came out, and the insurance companies are right now figuring out the policies surrounding this code. And so there was a recent webinar, and there were 30 payers on the webinar, big payers too, big to small. And the company asked them a couple questions, which I thought were very interesting. So they asked the first question, which was, do you have coverage guidelines finalized for this new code? So 80% of them said no, which points back to why I can't definitively tell you some of the answers to the questions I had on the previous screen. So I'm going to give you my best estimate, which, after doing this for a long, long time, I'm pretty confident in my estimates, but just like when I present a treatment plan and a financial plan, I'm pretty confident in my estimates, but it is not a sure thing. And so I'm going to say the same thing that I say to patients, is that, you can never predict what's going to happen with benefits, but based on my best estimate, this is how the environment is going to look. So remember those words. Based on my best estimate, this is what your benefits are going to look like. This is what the environment is going to look like. So second question, let's move on to the second question. Are you going to clinically review 4346 prior to payment? So, more than half of them still thinking about it. Roughly a third of them are not going to clinically review 4346, which is really interesting to me, which means that many of them are going to send them through as an auto adjudication method. And auto adjudication sounds like a big scary word, but it's not. Auto adjudication simply means that the claim is going to sail through without really anyone taking a look at it. It's processed quickly. Many of you have your claims auto adjudicated on a daily basis. You just didn't know that that was the term for it. It's surprising to me that a third have already said no. What that means to me, and this is my big bold prediction, is that when you get to 2018, you're going to have some real tightening up around the benefits on this code, because for those insurance companies that didn't clinically review it, they are really going to be looking at their out-of-pockets, how much they paid towards this code. And if it turns out that this has become, and as all new codes are, this has become a target of fraudulent dentists, then they may need to reverse course or tighten up that protocol. So, but again, almost 60% are still evaluating it, and so that number could get, it really could go at any direction right now. So what the big question is for us is the code going to be under preventive, or is it going to be under a periodontal service? It looks like about a third, again, just under a third, are periodontal service, and 62% are still evaluating. And, if I were in Vegas and I were putting down a bet, I would put down that it is going to be covered in the 4000 series, and it's going to be covered at about 80%, which is whatever your 4000 series is under. So type 2, basic, whatever you want to call that middle tier, that's where I think it's going to be. I would be very, very surprised to see the larger companies reimburse this as a preventive service with no clinical review. I would be very, very surprised if that happened. And so you're probably thinking, why wouldn't they just cover this at 100%? Why wouldn't they just cover this at, 80%? Why do they have to do all this evaluation? Why can't, if it's a 4000 code, why can't it just go right into the 4000 series? Well, they have to take a look at their numbers, and this is why, and this is just a tip about any new codes that come out. When you have a brand new code that comes out, you're not going to have a definitive, let me think about this here. It's not definitive. You're not going to have a uniform way of handling that code. You're going to have different insurance companies with different policies across the board, and then you see it starts to even out, because when a new code comes out, there's really not that much data on the new code. So if you think about it, when you bill a code, the insurance companies then come up with tons and tons of data based on that code. Then they track it down to the different zip codes, and they take a look at what is that going to look like? How much is that going to cost us for this region? And there's a lot of actuarial data, the numbers that go behind that. And so I'm not surprised that that there is no set one insurance company that's come out and said this is how it's going to be. They're still finalizing it, and that doesn't surprise me, because there's an awful lot of number crunching that goes on. But we are getting to the end of the year, and by the way, I'm hoping that you'll have all reached out to your patients that need to use up their insurance maximums by now. We are getting to the end of the year, which means that the plans that are being sold for next year, we've got to figure this out. And so in January, when the new code goes live, it is going to be up to you, insurance coordinator, to figure out how these codes are going to be handled. And it's going to be important to document that and to keep the team abreast of that as well. So with that in mind, let's go back to the questions. Will it be preventive or periodontal? I already talked about that. If I were in Vegas, like I said, I'm putting my money on periodontal. Can we bill for cleaning and perio maintenance or perio maintenance on the same day? Well, if you think about it, no, you can. It's not only is it precluded in the actual descriptor of the code, but 4910 means that we've already done some treatment to treat the soft tissue, to treat the gums, and So if we haven't done that, how are we doing 4910 on the same day? Well, then I get the question of, well, what about somebody who comes in and, they've got that puffy side and they've got that non-puffy side. They've had scaling and root planing before, 4910 on one side of the mouth, 4346 on the other side of the mouth. Your documentation is going to be a little wonky on that, which means I'm going to have a harder time getting that paid. So keep that in mind. You can bill for what you want to, but whether or not I can get it paid is not good. I would prefer that you bill for as close to the description of the code as possible. Is this going to affect frequency limitations? Probably. If there's one thing I've learned with dental insurance over the years is that frequency limitations are a very, very handy way to reduce the insurance company's payout, and it's business. It's business. I don't have any ill will about that. That's business. So frequency limitations tend to be very frustrating to us as insurance coordinators because they take us by surprise. So when it comes to that, I would make sure that when you're starting January, when you are calling to find out about the benefits for 4346, you're going to ask specifically, what are the frequency limitations that are tied to that code? I'm suspecting that 4346 is going to have a lifetime usage, and I would not be surprised if using 4346 precludes you from using 4910 unless it goes into scaling and root planing, which is the proper way for that's the proper pathway. But again, you're going to need to talk to your hygiene team, your clinical team about that. What am I going to, let me go back to frequency limitations. There is the cautionary tale of 4342, which is scaling and root planing 1 to 3 teeth. So that is where really the cautionary tale of frequency limitations comes into play. Everybody loved that new code when it came out. The intent was good. It sounded phenomenal. So doctors would treat 1 to 3 teeth because that's what they saw, and they would send in for 4342, and then we found out later that there was a frequency limitation attached to 4342, which kept us from billing out 4341 in the next 24 to 36 months, depending upon the plan. So what that meant is somebody who had 1 to 3 teeth, we would treat them, and of course their home care wasn't great. They didn't have the Sonicare or whatever it is that they have. They weren't taking care of themselves. So what they would do is come back and they would need scaling and root planing, and you'd think, okay, great, well, we didn't do 4341 before. Surprise, the frequency limitation attached itself. And so that is why I don't want you to have any surprises with that. It does not hurt to ask, especially if you've got the person on the phone. But again, having someone on the phone is a real waste of resources. I'm hoping that you're checking all of this electronically and you're able to get this information through an electronic pass-through. What do I need to send in to receive payment? Well, we're going to go over that, but really the 3 things that I'm going to look for as an insurance coordinator is a diagnosis. I'm going to look for good images, and I'm going to look for some perio charting. So if you've got great documentation in your notes, you give me a diagnosis, you give me a good write-up, and you give me some good images, and of course, periodontal charting, I'm thrilled. And for some of you that are thinking, well, who doesn't have periodontal charting? You'd be very surprised. I still run into offices where the front office administrator will come to one of my insurance classes and she'll say, I can't get any of my perio paid because the doctor or the hygienist refuses to chart. Well, that's a whole separate conversation, but that is not proper. So hopefully you can rectify that. And again, that resource guide is going to be great to look at, and you're going to want to check that out. I've got two books that I order at the beginning of every year. One is the ADA's code guide, the CDT guide, along with the coding companion. And the second book is, of course, Dr. Blair's book, Coding with Confidence. And so I just love the way both of those books are approaching coding. Is it overkill? Sure, but I'm an insurance nerd, so it's okay. I can do that, right? I like that. And if you have any insurance coordinators in your office, I would bet that they're insurance nerds too. So, if you want to give them a nice holiday gift, I would suggest getting them something nice, but as their gag gift for the office, get them a coding book and just see their face light up. I know, insurance nerd humor. So based on the indecision and the financial implications, let's go through what it looks like to have an evaluation, because really when I talk to you about evaluations and when I talk to you about documentation, again, I firmly believe that that is how you're going to get paid in the future. So let's look at this. Let's go back to the basics when it comes to evaluation. How are you gathering the information for your evaluations? You know, my preference is that the new patient is going to come into the practice with the doctor, you know, not the hygiene side. And I know for years, and I started in dentistry when this was all the rage, when the patient went in through the hygiene, you know, doctor would take a break, come in and do the comprehensive evaluation. And it was a very, very hard habit to break. But I've worked with enough offices and worked with enough doctors that I know that coming in through the doctor's side is a much better experience for the new patient. And for me, documentation-wise, it's the way to go. So, you know, a good reason for this is that you can't have a diagnosis and a prescription for radiographs or any kind of soft tissue treatment. You can't have that without an evaluation. Now, the evaluation has to be done in most states by the dentist. So if you're going in through hygiene, you know, again, unless you're in a state that allows it, you know, hygienists aren't legally able to diagnose or prescribe. And so that's one reason, that's one very, very strong reason to have them come in on the doctor's side. So when they come in, I'm going to take a look at their history, their medical history, their oral history. I'm going to take a look at their current conditions, and I'm going to document diagnosis, not just for periodontal disease, for caries. I'm going to take a look at risk assessments. You know, you're going to hear a lot about risk assessments coming up, especially when diagnostic coding comes along. And if you've ever taken any of my insurance classes, you know we talk about risk assessment. I don't teach risk assessment. I'm not a clinician, but I'm going to talk to you about how risk assessment works into how you get paid and what does that mean for your revenue. Intraoral images are crucial. You know, radiographs are great, and I can't get 90% of my claims paid without radiographs, but there are going to be cases like 4346 where intraoral images are just crucial. And let's just make sure that all of this documentation that you're gathering is translatable to the administration, the administrative team, because if your insurance coder, who may or may not have years of experience, if she can't figure out what your notes mean, then you're not going to get paid. And you're going to wonder why so many claims, we get this call all the time, why are so many of my claims getting closed out with no payment? Aren't they supposed to be appealing this? Well, yes, of course. So, but somebody without experience isn't going to know about that. So, you know, and if you do need to train your insurance coordinators, my company does have online insurance classes where they can learn all of this from home, online at their own pace. So there are resources for that. This is the gingival index that we were discussing earlier. And, you know, if you're not incorporating this index into your notes, now's the time to start. And the ADA does talk about this in their guide. I recreated the chart and, you know, happy to send this to you on a full page if you need it. I did put down there at the bottom, please check with your dentist. And the reason being is that, you know, I do run into clinicians who don't necessarily agree with what is in the textbooks. You know, they have their own style of practicing, and so I don't want to ever step on their toes. So admin, please check with your dentist. So, you know, he or she is who is driving the clinical decisions in your practice. So you're going to want to check with them on that. You're going to, of course, need indices when we move down towards diagnostic coding for the services. There's also a caries index that's created by the same team of dentists. And so, you know, there's all sorts of indices out there. If you go over to the AAP, if you go to the ADA, if you go to, you know, most of the large associations, they have great clinical resources. Most of your state associations also have that. So it's really a matter of looking around and finding them. We do need a rating in our documentation. We do baseline evaluation. And so, you know, this gingival index, when I see GI, that's probably going to be your abbreviation. If I see GI 3, then I know that this is this is a problem here. So I've got severe inflammation, increased redness. Does this fit? Is there bleeding and ulceration? Yes. Is there bone loss? If I see a no, if I look at the chart and everything's, 2, 3, but the gingival index is a 3, then that tells me 4346 is a great code to use for that. Same thing with moderate inflammation. And so if I see a GI of 0, then I'm not even going to think about 4346 when it comes to coding, because that clearly doesn't apply. And so that is really why we have these documentation tools and why we should use them. So I am a huge proponent of intraoral images, and I'll tell you why, and we'll get into a little bit of the flow of the exam. These are the same teeth. And I'm very appreciative of the dentists who are willing to share their images with me. Again, I'm not a clinician. If you have images out there that are similar to these and you're okay with sharing them with me, please let me know. I'm happy to feature you in these slides. But these are the same teeth. And so when I'm sending in payment for my scaling and root planing, you can see the radiographs really don't show what I can see clearly in an intraoral image. And that is why you'll hear me say often in classes, intraoral images are gold. They are like gold to me. I can get most claims paid with a good intraoral image if it shows the issue quite clearly. So some of you who, and I understand the frustration, some of you are probably thinking, well, how the heck am I going to start bringing new patients in through the doctor when I've got a schedule that's booked out for the next 6 to 8 months with all of the new patients on the hygiene side? Well, you pick a start date and you go with that. So, I'm not saying go in and change the whole office in a day. It's baby steps. If you go in and make massive change, any manager will tell you this. If you go in and make massive change immediately, there's almost no buy-in because there's just too much discomfort amongst the employees, and you're just not going to get buy-in with that. So it is doable. And this is the flow of it, and I'm happy to send it to anybody who needs it. But basically the patient, we're not going to spend too much time on this, but basically, patient, we're going to gather a lot of the information either before they get in the chair or before the doctor really even gets into the mouth. We're going to do an awful lot of oral history review, medical history review. We're going to do some risk assessments, and then we're going to get into where the doctor picks up an instrument. What other evaluation points are there? Well, you're evaluating hard tissue, soft tissue, tooth position, bite, jaw position, sleep apnea. I mean, my goodness, there's whole courses dedicated to what you look for in an evaluation. When the patient comes back, that's just the new patient evaluation. Then you have to have them come back, and I get a lot of pushback with that as well. And my verbal skills around that are, Mrs. Smith, I just need a little bit of time to take a look at your records. We'd like to have you come back in for a consultation. It's no cost to you, but then that'll give me a chance to really take a look at the records, and then we'll be able to have you see Sally or Rob for the hygiene appointment. So when the patient comes in for the consultation, the doctor is going to explain any of the treatment that's needed, and if there's a financial presentation that has to be made at that time, it's going to be made at that point in time. So, and then they go over to see the hygienist. Now at that point is where we will know, is this going to be a 4346 or is this going to be a 1110? Or are they bypassing everything and going straight into scaling and root planing because that's what they need? So you can't really make that decision until the doctor really gets in there and does that initial consultation. So, I'm sorry, the initial evaluation. When they schedule them for the consultation / hygiene appointment, the doctor will already know at that point there's bone loss, there's bleeding, this is where the patient needs to be, we need to go straight into that. It's a much smoother way of handling the patient and getting some patient buy-in. There's a lot more contact between the patient and the hygienist and the doctor. The hygienist is able to support the doctor recommendations. Interestingly enough, when it comes to the offices that switch over to this, they will tell me that it is a little bit nuts in the beginning because everybody's very nervous about this, but it really alleviates a lot of stress. And number one stress that's alleviated is the insurance coordinator having to put together a treatment plan in pretty much 5 minutes and check insurance benefits and have it printed and have 2 copies ready to go and have the calculator and have the forms and have the care credit up on the screen. I mean, I used to do it, so I know. It's a little tough. And so it's a different way of looking at it. So a few assumptions here is that, we're taking good diagnostic records. First of all, we're making sure that we check eligibilities and making sure the team's on board, but really the biggest issue here is that we're taking good diagnostic records. And that's why, if you can show me some, as your insurance coordinator, if you can show me images like this, I'm beyond thrilled. If you could give me documentation like this camera can, then I will have a much better way of sending, much more confident sending this in for payment. And obviously the tooth on the bottom is a rendering. It's not actually a tooth. But if you look at the pinkness around the tissue, so what this particular image does, and it's from a camera that is the Sopracare, and I got to give a shout out to my friends over at Inspired Hygiene. They are so on top of hygiene and teaching and training, and they're the ones who tipped me off to this camera and what kind of images. And they were very excited and showing it to me and saying, hey, this is great. Look at what we can do with our patients. And all I could think about is, oh my gosh, I can get my claims paid. So that's where I'm coming from, is look how cool this is. I can get my claims paid. So when I can show that there's a huge amount of inflammation, because look at that tissue. So it's the same teeth on the left and the right side. It's just that when you fluoresce it with this particular camera, it really shows not only the tartar, but it shows the gingival inflammation. I can't get that on a radiograph. There is no radiograph out there that shows me gingival inflammation like this. And so, as an insurance coordinator, I'm dancing. I think this is phenomenal. If the code is to treat a diagnosis of moderate to severe inflammation, then it's on me as the insurance coordinator to show that. And this particular image here, if I were to send that in, I mean, you can see the gingiva is definitely inflamed. Again, I really need good images as your insurance coordinator in order to have things paid. And so here's an example. It also lights up caries too, so you can see the plaque that's in there, and I'm sorry, not the caries, but the plaque. But you can see, just I'm paying attention to that gingiva. I really am going to rely on these to get 4346 paid more so than an actual radiograph. And hopefully I'm going to have good periodontal charting to go along with it. Now, another code that's new for 2017, and everybody is so concerned with 4346 that they're not realizing there's actually an implant code that's coming along as well, is 6081. And that is scaling and debridement in the presence of inflammation or mucositis, that's a lovely word, on a single implant, including the cleaning of the implant surfaces, without flap entry and closure. And so this is when you have that implant site, and we need to, there's a lot of scaling and inflammation, and you can see that they're doing some air polishing there, and then they're using that instrument to clean around there. But basically that's scaling in the presence of the inflammation of a single implant. We never really had a code for that before. So just know that you have that. But again, a radiograph wouldn't show it the way that I would like it to be shown. It's really just not that helpful. So for this code, I would actually bet that it's not going to be in the preventive section. So you know how we were wondering if 4346 is going to be preventive or restorative. It's 6081 is going to be firmly in the implant class, and so you should plan on that. A couple points to consider as we wrap up our discussion on 4346 is that, periodontal charting is still going to be crucial. My intraoral images, I should just cross out will be important and really just put, is necessary, is a must, is essential. Hopefully I'm getting that message across. The lack of bone loss, it just means that those radiographs aren't as essential. They're not as helpful for benefit consideration. And so, you know, if you have a doctor out there that doesn't have a good intraoral camera or is just not in the habit of using it, just know that for 4346, if he or she plans to bill for it, then they should plan to not really get reimbursed for it. So, you know, I would present it to them in that manner. 4910 is not an appropriate follow-up once you've done 4346. That's going to be the next question that I get in classes is, you know, we've done 4346, so they're not a 1110 anymore, right? They're a 4910. Well, there's no attachment loss, and so 4910 doesn't really count. You know, hopefully with the 4346, the goal of 4346 is to get them back to a healthy state without having to do anything invasive like scaling and root planing. And so hopefully 1110 is the code that you're going to use for that follow-up, for those follow-up preventive appointments. Now, patient conversations that you're going to have around this code is you're going to have patients who come in and think, oh, I thought I was getting a cleaning, and you know, well, oh my gosh, this is going to cost more, and there's always the perennial, is this going to hurt? I'm not going to tackle that question because hopefully you've discussed that in your office as a whole. Here's some conversations that the doctor could use, and again, I'm happy to send these to you. So the doctor is taking a look at the mouth and is having to break the news to Mrs. Smith that 4346 is what we need to do. Mrs. Smith, after reviewing your information and having a good look at your mouth, you know, it looks like we're going to have to take care of this inflammation and bleeding before we can move forward. That's my first priority when I take a look at your mouth. We're catching this early. Right now, you don't have any bone loss. And what I mean by that is all I see right now is puffiness and bleeding, but we do need to treat that before it gets to a more advanced state. This procedure is going to help with that, and if you're able to keep this up at home, then we may not ever need to worry about your gums again. So this is really something, when I speak to the patient about this, my tone is going to be sympathetic, as always, but it's also going to be educational, because what I'm saying to them is, if this, then that. And so I need to make that connection for them. So right now, there's just puffiness and bleeding, which to a lot of people, that doesn't bother them. So if we do this now, then it won't get later. If we do this now, then we can prevent a more painful procedure later, a more costly procedure later, whatever that driver is that you identify for that patient. Now, as an insurance coordinator, you know, we have totally different conversations than what happens in the back. Some of them are more pleasant, but mostly they're just a little bit more meat and potatoes, a little bit more direct. You know, why don't you know about this procedure is what we're going to get. Why don't you know what the benefits are? Why am I getting this done? Why is it going to cost more? So doctors, you should know these are the questions that we get peppered with at the front. You know, Mrs. Smith, we've done this procedure for many years. We just now have a code for it. What that means, because they don't care that you just got a code for it. They don't care about that. So what that means is that it's a new code for all insurance companies. So when we checked your benefits, we were told that it was going to be covered at 80% after your deductible. The reason I told you it was a new code is because there's always a chance that it won't be covered. No one in the industry knows 100% how this code is going to be handled, and this is what you would say to the patient, because it's true. I'm not bashing the insurance companies. We just don't know how it's going to be handled. You don't have enough experience to make that call. So I'm telling you, Mrs. Smith, about it being a new code because there's always a chance that it won't be covered, but if that's the case, we're going to let you know immediately. And I mean that. That's the customer service part of it. And then I always end with, how will you be handling your portion today? Because if you've been to my classes, you know my mantra, co-payments are meant to be collected. And so I want you to make sure that you collect those co-payments. I'm going to give you a little bit of homework today before we wrap up, and I will take a few questions. I do see a bunch of questions in the queue, and if I don't get to all of them, I do have a copy of them all, and I will make sure that they get answered. But let me give you some homework, please. And I'm serious because I know that there's going to be a lot of catch-up conversations that you're going to have in January if you don't have these conversations now. Every time there's a new code, it happens every year. So I wanted to give you the jump on this, and that's why I was so thrilled when Acteon asked me to present on this, because they recognize this is going to be a big pain point for all of you. So as your insurance coordinator, you're going to go back and I'm going to urge you to have these meetings. So doctor and hygiene team are going to get together. You're going to meet and you're going to determine your periodontal protocol. Now, for most of you, you'll have this set. You'll already have an idea of what this means. We don't facilitate those conversations, but I'm happy to point you to resources. Like I mentioned earlier, I'm happy to point you to resources who can help with that. So you're going to meet and determine your own periodontal protocol. Then you're going to meet with the whole team to discuss new protocol. Then you're going to review the verbal skills attached to all of this for all of your members. So that's the important part. And that's not just one meeting where just one person talks. That is going to be a meeting where a lot of people talk. Then I'm going to have you discuss the role of documentation so that everybody understands why documentation is so important. As your insurance coordinator, I'm going to be grateful for protocols, and I'm going to be grateful for an increased effort to improve documentation. Your records, along with my insurance knowledge, that means more revenue. And honestly, it just doesn't get much more simple than that. I want to thank you for taking your time to spend a whole hour with me on the phone talking about insurance. I want to thank Acteon North America for supporting this CE and also for being a firm supporter of documentation, which is I'm always going to be a fan of that. I urge you to connect with me on my Facebook and through Twitter and my website, which has a sign-in box if you'd like to sign up for my newsletter.